Hello and welcome to Live from AUA 2025, Advances in ADT. We strive to offer outstanding educational courses and greatly appreciate your evaluations and general feedback so that we are able to continuously improve our programs. We thank you for joining us. Before we get started, we'd like to go over a few items. I'd like to extend a special thank you to our course director, Dr. Kristen Scarpato, for her tremendous efforts to plan this activity. We thank you for your dedication and commitment to urologic education. Thank you as well to our distinguished faculty, Pedro Barada, Michael Cookson, Rachel Hastings, and David Morris, for their time, talent, and expertise. The AUA is accredited by the ACCME and designates this enduring material for a maximum of 1.0 AMA PRA Category 1 credits. The AUA is not accredited to offer credit to participants who are not MDs or DOs. However, the AUA will issue documentation of participation that states that the activity was certified for AMA PRA Category 1 credit. All persons in a position to control the content of an AUA educational activity are required to disclose all relevant financial relationships with any ineligible company, formerly known as commercial interest. Please visit AUA University to view Faculty Education Council and COI Review Work Group disclosures. The AUA would like to thank Pfizer, Inc. and Sumitomo Pharma America, Inc. for providing independent educational grants in support of this activity. This activity is meant to be educational in nature, and in some instances reflects the opinions of the presenters. The information does not guarantee accuracy of claims submitted. Please verify the accuracy of individual medical claims submitted, and please follow individual insurers' rules. Thank you for attending Live from AUA 2025. I will now turn the program over to Dr. Scarpato.
Thank you for joining us today at Live from AUA 2025 to talk about advances in ADT. My name is Kristen Scarpato. I'm an associate professor of urology at Vanderbilt University Medical Center, and I'm honored to be able to moderate this timely discussion today. I'm here with Dr. Pedro Barada. Dr. Barada is a board-certified fellowship-trained medical oncologist at University Hospital's Seidman Cancer Center and an associate professor of medicine at Case Western Reserve University School of Medicine. He serves as the director of clinical research of GU Medical Oncology Research Program and the co-leader of the GU disease team. Dr. Mike Cookson, he did his urology residency at the University of Texas at San Antonio and a fellowship in urologic oncology at Memorial Sloan Kettering Cancer Center in New York. In 2013, he joined University of Oklahoma College of Medicine, where he was appointed professor and chairman of the Department of Urology. He has published extensively. He's currently the vice chair of the AUA SUO guidelines on advanced prostate cancer. And in 2025, he was elected as a trustee to the American Board of Urology. Rachel Hastings, she's a physician assistant in urologic oncology at NYU Langone Health in New York. She has been working there for just about 3 years, and prior to that was a team leader for robotic surgery and prostate cancer. She's worked at both academic institutions, including Penn, as well as a community setting in New Jersey, and has 17 years of experience in the field of urology. Dr. David Morris is the president and director of Advanced Therapeutics Center for Urology Associates in Nashville. He graduated from Vanderbilt University and completed his residency training at the University of Michigan in Ann Arbor with special research interest in genetics and genomics related to prostate and bladder cancers. Welcome to you all, and thank you for joining me today. Prostate cancer represents the most commonly diagnosed solid organ malignancy for men in the US and is a leading cause of cancer death. Deaths from prostate cancer are typically the result of progression to metastatic castration-resistant disease. Moreover, the incidence of metastatic hormone-sensitive prostate cancer has been increasing in recent years. Notably, advanced prostate cancer represents one of the active areas of investigation in GU malignancies, and there have been many exciting developments in recent years in androgen deprivation therapy in the management of patients with advanced prostate cancer. This AUA 2025 included a number of programs covering ADT, and our goal today is to discuss a bit further several of these. So let's start by talking about ADT recommendations across the guidelines. While throughout the course of the discussion, we will focus more on advanced prostate cancer, it's important to know that ADT is used across the landscape of the management of prostate cancer, and it was discussed at various sessions throughout the AUA 2025 meeting. Dr. Morris, you were involved in several important sessions during this AUA, including the International Prostate Cancer Forum. Can you just briefly highlight, as we get started, where we see androgen deprivation therapy indicated in the prostate cancer guidelines? Because it's there in several places.
Sure. Just a high level view for those of us managing a lot of prostate cancer, obviously localized disease. In the salvage setting, there's also guidelines related to ADT use, and then extensive information around advanced disease use of ADT. And I think the most recent information that has to do with localized and salvage, there's been AUA updates in the guidelines related to localized and in the salvage setting ADT use. During this AUA, there was obviously updates in terms of predictive models on choosing appropriate duration of ADT in both the localized and in the salvage setting. But typically localized, we're using shorter courses of ADT for unfavorable intermediate risk disease. And then when we're reaching a higher disease risk category, typically it's 18 to 36 months of ADT. There's been a lot of interest in de-escalating some of the ADT exposure in men where they may be able to forego some of the side effects and toxicity of ADT. And so there's been AI models proposed. There's genomic testing from a multitude of commercial companies that can help suggest higher genomic risk versus lower genomic risk. And in several retrospective analyses of randomized clinical trials, it appears that you can pick out patients who may be able to forego some of the added ADT toxicity, especially in the intermediate risk disease, where it's a little more unclear who's going to derive benefit. Basically, almost every high-risk man needs therapy, and actually there's several ongoing studies looking at intensifying beyond just ADT in the highest risk men with bad genomic factors. And then from the salvage side, there was an update to the AUA guidelines on salvage therapy that was released. Basically, any high-risk factors associated with their disease characteristics, which could be grade group 4 or grade group 5, significantly elevated PSA doubling times that are fast, less than 6 months typically, is kind of a cut point in the sand. Persistent post-op PSA levels that don't nadir to zero, and T3B status or seminal vesicle invasion at the time of prostatectomy. The guidelines now support ADT use for a minimum of 4 to 6 months with salvage radiotherapy. And in the highest risk factors, you can actually extend that out to 18 to 24 months. And there's several genomic factors that are being utilized in this setting as well, from a post-op, post-RP situation, trying to kind of call out the highest risk individuals that may benefit from more ADT at the time of their salvage therapy. And then one of the last updates that's kind of was discussed in one of the courses, the Prostate Cancer Update 2025, was a recent analysis of the Transport trial, which is a kind of a review of 5 kind of combined clinical trials looking at ADT duration for radiotherapy patients, and really focusing on testosterone recovery. There's obviously well-known from our personal experience using ADT that these instruments are not directly out of the system as soon as the date of their injection or oral therapy stops. And so the tail for ADT has been well described, and this is just a really nice review that's from multiple trials combined together, showing that 4 to 6 months of ADT can often lead to castration out to a year for those patients. And longer durations, 18 to 36 months, can often lead closer to 4 years of castrate status. And it can take a long time not to just get castrate and get above a testosterone of 50, but much longer even to reach a eugonadal state or non-hypogonadal. And so there's some particular interest in that sort of situation where our clinical factors have suggested these 6 months and 18 months duration of ADT, but in the real world, that often means that they're castrate for longer than that 6 months or that 18 months. And so with newer agents being investigated, certainly some of the antagonists have potentially faster testosterone recovery than our historical agonist depot injections. And so there's a clinical concern of if we turn off the testosterone suppression faster than what was done in those historical trials, saying 6 months, we may need to be more cautious about the idea that their testosterone recovers faster, and they may not get the same benefit that was seen in those studies that really gave 6 months of an agonist, but actually had a tail of 6 months of castration that followed it.
Yeah, no, I think that those are some really important points that have implications for oncologic outcomes for our patients, and also how we counsel our patients about the expected duration of side effects. And certainly we'll get into a discussion about side effects afterwards, but really interesting when, especially the newer oral antagonists came on the scene, where I think we're all using it a little bit more regularly now. And so I like to tell patients, it's quick on and quick off, but while they like that, what does it mean for them from an oncologic standpoint when they're using it for localized disease with radiotherapy? Well, thank you. That was a nice comprehensive review there. So let's talk now. You mentioned treatment intensification. And so I'd like to talk to Dr. Cookson about treatment intensification. That's a term that we hear used quite a bit in advanced prostate cancer, and it's a really important concept. So in patients who have biochemical recurrence, and there's kind of two forms of biochemical recurrence that I think of, what we just talked about. So patients who have biochemical recurrence and can receive some additional local therapy. And then there are patients who have exhausted opportunities for local therapy. And that's what we see in the advanced prostate cancer space and guideline. And you were on the AUA Advanced Prostate Cancer Instructional course, as well as the Evolving Landscape course, both of which were really successful. So can you talk about ADT for those patients?
Absolutely. Thanks for inviting me to participate in this. Until recently, biochemical recurrence was like the last disease state that really didn't have support for using ADT, really, except for a little bit of ADT intermittent versus continuous in a monotherapy fashion. But it really didn't have any good data to support the use of androgen deprivation with AR-targeted therapies as well. And then about a year ago, a little over a year ago, two trials have come forward. One was called Embark and the other was Presto, but they both looked at patients that were relatively high risk for development of progression of their disease when they were found to be exhausting of local therapy and a rising PSA. And they looked at the role of conventional ADT compared to, say, an additional AR target. So I'll kind of focus a little bit on the Embark one. That's the one most people are more familiar with. These patients, to be enrolled in the trial, they were enriched with rapid PSA doubling times. So you need, 3-4 PSAs over time to really calculate that. But if your PSA doubling time was less than 9 months, and then in the situation where they had failed radiation therapy, kind of greater than 2+ nadir, or failed surgery where they enrolled at greater than 1, those patients were then randomized. And so one arm was just leuprolide alone, and a placebo. The other arm was leuprolide and enzalutamide. And then the other arm was enzalutamide monotherapy. The patients were continued on their therapy. And at about 9 months, they were then assessed. And if they had a really robust PSA response, and in that trial was defined as less than 0.2, they could then go into intermittent therapy, hold on their treatment, and then be monitored. And then the primary endpoint of this study was metastasis-free survival. What they found was in the patients who were treated with the combination of leuprolide and enzalutamide compared to leuprolide alone, there was significant metastasis-free survival. And it was, I think it was about a 50% improvement overall in their outcome. When they looked at that ability to get to the point where you might consider intermittent therapy, about 90% of the patients who were in the combination arm were able to withhold therapy, go on a drug holiday, if you will, as compared to about 67% in the leuprolide alone. And most exciting was that durability of their response. So in the patients that were treated with the combination of leuprolide and enzalutamide, on average, they had like 20 months of time off of therapy before their PSA would rise again. and then they would resume therapy. And that's compared to about 16 months in the leuprolide alone. There was the enzalutamide only arm, and that is attractive for some patients who are very prescriptive, that they want to preserve their testosterone. So there is a way to block the cancer and lower the PSA while preserving their testosterone levels. So that's an important component of the study. In my own practice, probably use that on a select group of patients, and more of them are on the combination. But it is important to note that there are side effects to these. Hot flashes are common, much more reduced in the patients on monotherapy. And there is fatigue associated with all of these regimens, but well tolerated, and patients were able to, get through the treatment quite well. So it opens up the opportunity for us to intensify, if you will, for a shorter period of time in order to give them longer time off of therapy. And, finally, we have some information on that. The Presto trial was a little bit different. It was patients were enrolled in it with a PSA of greater than 0.5. They had no evidence. These are conventional imaging, I must say, too. So we can talk a little bit later about how the confounding ability of PSMA PET has sort of changed the population of what was in these studies. But we didn't have PET scans in these studies. And so in the Presto study, they were looking at ADT alone, ADT plus apalutamide, or ADT plus apalutamide and abiraterone, so kind of a triple therapy. And their primary endpoint was PSA progression-free survival. And in that study, again, the intensification arm outperformed the leuprolide alone. And not surprisingly, they had a significant impact on that PSA progression-free survival. So we have some options now. Before, we would just say, well, there was a study that kind of gave post-radiation failure patients some ADT, and compared to intermittent therapy, it's probably about the same, but we didn't really know when to stop, or if we could stop, how long we would expect it. So these have been some breakthroughs for those patients at high risk for recurrence with those rapid doubling times.
Thank you. Yeah, two really important points I just want to highlight about what you said. One, this is really the last space in advanced prostate cancer where we had yet to see treatment intensification and the addition of androgen receptor pathway inhibitors. And so now we see that here, which is important. And two, both of these trials, as you said, enrolled patients who had had conventional imaging. And conventional imaging is not what we're using as often these days. We're seeing so much more use of PSMA PET. And so these patients may actually be, or those patients in the trials may have been reclassified as having more advanced disease. So there is a trial that is underway called ARISTEP that is looking at darolutamide and ADT for patients who have high-risk biochemical recurrence. And this is a phase 3 randomized, double-blinded, placebo-controlled trial. And patients here do have PSMA PET positive disease, is my understanding. So really kind of exciting to see what comes out there. And we, again, need to be really thoughtful about the side effects of these agents and consider that this is largely an asymptomatic population, right? So patients who have lab abnormalities but aren't necessarily experiencing any symptoms from their disease, and now we're throwing some pretty important quality of life altering medications at them, and so it's really a balancing act.
Yeah, but and I know, when you have these high-risk patients and they're watching their PSA rise, and it's terrifying to them, and even with ultra-sensitive PSAs, we know that difference doesn't seem as meaningful to them, it's profound. And so the ability to put them at ease, to comfort them and let them know that, this will reduce or stave off the time to development of that bad event, which is the development of metastatic disease, and that was conventional imaging. They're usually pretty willing to undergo one of the different regimens that I described for that high-risk group.
Yep, absolutely. Also important to note, kind of after what Dr. Morris just told us about testosterone recovery, there was a presentation at the AUA from Dr. Friedland looking at a post-hoc analysis of EMBARK. They were evaluating testosterone recovery in patients who were treated with enzalutamide combination and leuprolide alone. And this was for the patients that he had mentioned who suspended that Dr. Cookson mentioned, they suspended therapy. So patients who had a good PSA response, I believe it was at 36 weeks, were able to kind of hold on therapy, and they looked at recovery of testosterone. And so we see that the vast majority of patients treated with enzalutamide combination or leuprolide alone fully recovered their testosterone levels during the suspension. And that was kind of irrespective of their age subgroup. And so this may explain why hormonally treated related quality of life was significantly improved in that group of patients who had treatment suspension. So now I'd like to hear a little bit from Dr. Barada again on this topic of treatment intensification for patients who have metastatic hormone-sensitive prostate cancer. This is a space that has just exploded and changed markedly over the past decade, and we see so many new medications and things kind of moving up into this space that were previously just for patients with castration-resistant disease. So I know you were at the Advanced Prostate Cancer Evolving Landscape course, and during that forum, we heard a lot about best practices. So can you talk to us about treatment intensification, the different forms of ADT, and why adding these novel hormonal therapies and maybe chemotherapy adds benefit?
Sure. Thank you so much again. Also a pleasure to be here among colleagues and friends. So yeah, as you said, Christian, well summary is a great summary. In fact, this area of metastatic hormone-sensitive disease really exploded, and the thought process was quite simple. We have therapies that work later on for castration-resistant disease, and we try them out in addition to hormones for hormone-sensitive disease. Right, we did that with chemotherapy first, Taxol, and then we did that also with different forms of. We used to call them novel hormonal therapies. I guess some of them are not novel anymore. So we changed the name to, or designation to, ARPIs, or androgen receptor pathway inhibitors. And if we were to analyze that data, we clearly see a benefit of the addition of, you pick, Taxol, ARPIs, or even both, along with ADT. Now, the conversation is always the devil's in the details, so it's a lot more complex than what I just said, for the following reasons. Patients can get here in two different ways, right? They can get here because they walk in the clinic with metastatic disease. Those are known to have newly diagnosed metastatic disease. And the second group of patients that are being managed by our urology friends, and whether they're post-surgery or even post-radiation, we end up scanning them and we find recurrent disease in different places of the body. Those are known as metaconus or recurrent disease. So you have two ways to get there. The other aspect is the amount of disease that you present, or tumor burden. We tend to call that volume, high volume, low volume, but basically go after the definition we use in the first of all those treatment intensification trials, called CHARTED, where we define high volume by 4 or more lesions in the bones outside the spine and pelvis in artificial disease. So the reason I mentioned those 2 points is because even if we forget the genomics that Dr. Morris alluded to, which is really relevant also in the metastatic setting, if you just go after clinical characteristics, you find patients with much different outcomes, right? Newly diagnosed high volume disease tend to do the worst. Patients with recurrent low volume disease tend to do the best. So that's one part of the story. And when we look at that, we really learn from all the treatment intensification trials that do something on top of hormones, castration. It's better than castration alone. Speaking on castration, different ways to get it. Surgical castration, which is reserved to a very limited number of people. We still see some reports on that. But most patients will end up getting medical castration, whether it's with an LHRH agonist or LHRH antagonist. Here, because the plan is, to continue on treatment without a plan to stop it, we don't have those concerns as much as Dr. Morris alluded to regarding, the time that we're doing it is really the time we're blocking it and inhibiting the dose of testosterone, because the goal of the game is to preserve or maintain that testosterone suppression for those individuals. And so often we have a conversation around cardio-oncology and whether or not bringing up relugolix versus leuprolide, gozerlin or others, is the right approach for a patient. But really where we spend a lot of time in our clinics is talking about what goes on top of ADT. And by the way, an important note, we no longer consider first-generation antiandrogens like bicalutamide or flutamide as part of that group of ARPIs. We now call them, consider ADT alone. So that's a concept that was not like that 20 years ago, and now it is. So ADT equals ADT and first-generation antiandrogen. That's considered obsolete. And why is that? Well, because when we bring an ARPI on board, you're able to improve pretty much all the efficacy endpoints. Those patients tend get a longer time to progression. You delay time to next systemic therapy. You delay time to chemotherapy. You're able to make them live longer significantly. The aspect in this setting is the delta, meaning the difference in overall survival is measured in over a year, favoring the combination of the RPI with ADT compared to ADT or ADT with first generation bicalutamide or flutamide. So the question is not really if ADT works, yes or no. We all know that the vast majority of patients is going to work. It's the question, is the game of played in many, many years. What's going to happen 4 or 5 years later? And so from that perspective, really bringing on, whether it's abiraterone, a CYP17 inhibitor, whether it's bringing an anti-androgen like enzalutamide or apalutamide, is actually the right thing to do. Speaking of that, so right now we have ABI, ENZA, APA approved as RPIs, but we actually have new data from darolutamide, I guess the newer kid on the block, a novel ARPI with perhaps similar efficacy, perhaps a favorable safety profile, darolutamide compared to the other anti-androgens. And that trial to support it, to support these, what I just said is called ARANOTE, which is actually an ex-US trial, and where patients receive ADT plus darolutamide and did remarkably better than patients who receive ADT alone. We're going to wait what happens to overall survival, had relatively short follow-up time at that point. Time to progression was prolonged significantly compared to ADT alone. I predict, actually, we're going to see a survival advantage favoring patients treated with darolutamide with ADT. The other aspect is, what about the U.S. experience? And we're going to have ARASEC trial to build upon the data from ex-U.S. And I think that was going to be a strong case for consideration of the regulatory agency in the United States. So I actually think in a short period of time, we're going to be having not 3, but actually 4 ARPIs available. We're going to pick one of them. The other aspect has to do, what about chemo? I mentioned chemo early on. Should we do that for everybody? So what we learn over time is not everybody benefits from chemotherapy. It appears that, by contrast, most patients, if life expectancy is impacted by prostate cancer, benefit from addition of ARPI, particularly anti-androgens. And so the question is, chemotherapy, who to give it to? And it appears that patients with high volume disease, specifically, and synchronous disease, seem to derive the most benefit from it. And we have 2 pieces of data, very relevant trials, PEACE-1 and ARASENS, that basically demonstrate that the triplet approach of doing ADT with an ARPI and docetaxel is superior to ADT docetaxel alone. So on those 2 trials, and there are a little bit differences between the design of the 2 studies, because of these 2 studies, plus all the others showing a superiority of RPI on top of ADT, actually ADT plus chemo by itself stopped being a standard of care. So it's really ADT RPI plus minus docetaxel these days. And then the decision around the addition of docetaxel to the backbone ADT RPI has to do with many factors: volume of the disease, timing of metastatic disease, chemo fitness, if you will, comorbidities, life expectancy, availability, patient choices, etc. So there's a long list that makes us think that the triple regimen has been reserved to 10 to 20% of the patient population that we intend to see in clinical practice. The vast majority of the patients should be receiving a combination therapy, including an RPI. If we want to do a triplet, we are really thinking of darolutamide based on ARASENS with docetaxel, or abiraterone with docetaxel based on PEACE-1. So it's, as you can see by my description, and I'm trying to keep it short, and I haven't even mentioned genomics, which, by the way, kudos to AUA guidelines recommending a conversation around germline testing for everyone in the advanced setting, and also consider somatic testing upon progression to CRPC. So I'm not going to mention much about that yet. However, we can quickly understand that the field has changed dramatically compared to 15 years ago, and is actually a multi-step approach where we need to talk about many different things. Prognostic, timing, volume of the disease, prognostic factors, castration, concept of castration, explain what bringing an RPI means and to the patient, and then perhaps chemotherapy considerations in addition to genetics. So all of that is happening or should happen within the first 2-3 months. I think, to conclude, I think multidisciplinarity is really relevant. Working with the colleagues, I haven't mentioned role of radiation to primary tumor, which is something that can be considered as well. So working with urology, medical oncology, at times radiation oncology, genetics, is really relevant. And this is really a field where things will continue to evolve. I predict we might have a little bit of time to talk about later today.
Thank you so much. So how do you tell your patients, or what do you tell your patients about the need for adding a second agent to ADT? In Dr. Cookson's advanced prostate cancer course, he always talks about the history of the discovery of ADT and the award-winning work of Huggins. And why is it, in patient-friendly language, what is the benefit of adding one of these androgen receptor pathway inhibitors?
Yeah, so in my clinics, I tend to do that on my visit number 2. So I kind of, have a systemic way of approaching this. So the first visit is really introducing the concept of castration. Why suppressing testosterone levels? Why do we do it? What do we expect to see? We tend to see the patient 3-4 weeks later, confirm testosterone suppression. And at that point, we bring the RPI. Why do we do that? So the way to simplistically approach that is, listen, you're doing great. This is working. At that time, PSA is already dropping. So it's not a PSA game. Patients are not PSA. PSA is going to go down. So we should not use PSA to decide who gets it and who doesn't. The vast majority of the patients are, even those with very nasty disease, if you exclude the small cell or extensive neuroendocrine features, which by the way is rare, well over 90-95% of patients will respond to ADT, as minimal as 6 or 9 months, right? The time to progression on ADT alone is measured about 1.5 years or so, something like that, 20 months. So when we bring the RPI, we really explain the biological reasons and then the pragmatic reasons. So the biological reasons is the intensity of blocking the androgen signaling pathway, which kind of feeds prostate cancer, is dependent on androgens, if you will, allows us to put a cancer to sleep for a much longer period in time. When you look at the median time on treatment, you're going from about 1.5 years to about 3 years. We're just talking about 50% of the patients, right? So, and that translates in overall survival. You're able to live longer. So you explain to your patient that, number 1, PSA is likely going to go down. 2, you're not a number. Number 3, if you want to use an early predictor of outcomes, you might look at PSA of 0 as a way to get that. Patients on ADT alone get a much smaller chance of getting a PSA 0, not dropping, but PSA decline, but PSA 0, compared to patients with ARPI plus ADT, which about 2/3 of them end up getting there, overall speaking. So by doing that, by doing this intensified way of suppressing the androgen signaling pathway, you're able to delay all the relevant aspects. So I'm going to tell my patient, listen, we're going to stay on this for a much longer period of time. Patient tumor is going to go sleep. We're going to delay the need to do something else. We're going to delay the maybe symptoms that you might develop from the spots that you might have in the body that you can see, and you're going to live significantly longer. And by the way, you can do that without compromising quality of life. So the important relevance of why you do all this is because no longer you're going to live longer, but you're actually able to live at least the same as if you're not getting it, right? So if you take the financial considerations aside and access aside, assuming patient is compliant, there's really no reason for us not to do it. Nonetheless, as you know, half of the patients are still not getting it for a number of reasons that we can expand on. And so it's really a game of many, many years, right? We've improved median overall survival significantly. Think of what we were, 5-7 years ago. And when you look at the orteronel trial from SWOG just conducted in the US, median overall survival is now measured, in about 7-8 years, right? So that means by treating better patients, they're able to, live their lives for longer and live it as well as possible. So most patients, or the vast majority of the patients, do understand this and actually feel okay with that. And then the questions always comes up about, okay, what am I going to do? Am I going to take a pill every day? Do I need to fast? Do I need a steroid? That's abiraterone. Or can I take it twice a day? Is there a problem with the other medications I take? I'm taking anticoagulation. I'm taking high blood pressure medicines. That is the part of the conversation that's also relatively recent to us, because understanding the drug-drug interactions of the different ARPIs, understanding whether or not you need to take it fasting or with or without food, once or twice a day, that matters to patients, right? And so that's where we're going to spend a little bit of time for them to be on board with, getting on it and stay on it and be complying on it. And to be fair, most of the times is a successful case. Conversations go quite well. In a few cases, we have to, to try to go through the pros and cons and until, and patients, do understand that. So I think most of the times where patients are not offering a combination has to do with us more than it has to do with the patient. It's not 100% like this, but I do think we play an important role explaining the importance of doing these combination strategies for them.
Yeah, I agree. I think it does have a lot to do with us, and we are doing a better job, but I know that all of us see a high number of patients in our clinics who are still on ADT monotherapy, and sometimes that's appropriate. We all know those patients who, have fit into a category that's okay. But if you look at our guidelines, we know that the majority of patients with advanced prostate cancer need and can tolerate and will benefit from combination therapy. So ADT monotherapy, the numbers aren't where we want it to be with applying additional therapies there. One thing that you kind of started off saying was you talked about surgical castration as an option, and I just wanted to ask Doctors Cookson and Morris about that in their own practice, and I can share what we're doing at Vanderbilt. But are you treating patients at all with surgical castration as opposed to medical castration, and how frequently?
I'll take first stab. It's relatively rare. It usually is a patient for either financial reasons, was anxious about medications, and it is a very small subset now where I don't consider de-escalating therapy in the future, and so that doesn't give us an option if we've done surgical castration. So it's somebody typically who would be high volume, who's going to be on ADT for the remainder of their life, and they just wanted a simple option. And it is a simple thing to do. We probably don't offer it as much as we should, but we're also thinking about trying to get people off ADT in this current climate, and so that's always a consideration. That it does take away some options down the road.
Yeah, I'd agree that it's a minority. I mean, it's just not a hot seller in the clinic. Patients don't want to sign up for that. There's always the hope of intermittency, even in the advanced and metastatic state. Once they get good control and you've gone a couple of years, there's no turning back with the orchiectomy. But when it is an option for patients, I agree it's a relatively simple. And if cost were a bigger issue for many patients, that could be a driver, sometimes pain, but it's an exceptional one that usually opts for that early on.
Yeah, similar where I practice, not the majority by any means, but I do think we offer it quite regularly, and I'm surprised more and more that some patients are taking that as an option. But when we're talking about kind of achieving castration, we have the injection therapies, we have oral agents, and then we have surgical castration. And as far as we're all aware from an oncologic standpoint, they're essentially all kind of equivalent and side effect wise as well. Maybe a little bit quicker on, quicker off with some of the therapies as we talked about before. So let's transition now to talking about some of the really important side effects of ADT, either alone or in combination. We know that these are really important quality of life side effects, and we just would love to be able to counsel our patients thoroughly and make sure that we're making safe, patient-friendly choices. So Rachel, can you share with us some of the common side effects associated with ADT use?
Yeah, certainly. Unfortunately, ADT has the potential to affect nearly every body system. It can be quite overwhelming for patients. I think the most common things that we see, hot flashes up to about 80%, sexual dysfunction, loss of libido, ED, 50 to 90%, and fatigue are probably the most common short-term things. And then in the long term, we need to consider bone health, as ADT can increase risk of fracture and osteoporosis in about 40%, goes much higher as we consider long-term ADT. Patients have about a 25% increased risk of metabolic syndrome, 20% of dementia, increased risk of Alzheimer's, and then the cardiovascular risk. Some of that comes from the increase in the metabolic. Some of it also comes from direct cardiac or thromboembolic risk. We do love data too, but I like to tell patients that, no one's a statistic and these things affect everybody differently. We need to assess at the visit, what are your risks and what can we do to mitigate those? And kind of start that conversation up front on our first visit.
Great. And so how do you start your conversation with patients when you're talking about side effects? If it's a brand new patient who's never been on ADT previously, how do you introduce the topic?
I think it can be challenging because there's a lot coming at them that first visit. They're getting a new diagnosis, they're getting a treatment plan, then we're throwing all these potential side effects at them. And I think some clinics, they tend to sort of skip over it or try to minimize it for these patients. And I strongly, strongly feel that is the wrong thing to do, because it will save you time. It will obviously save your patients some side effects, but it will save you time on the back end. So really just educating and using it as a moment of empowerment, take control to assess their health, see where they are, what can be better, what do we need to work on first, and then things that they can do to kind of take charge. We start there, and then educate the patient on the medication. What is it doing? I think a lot of misconception is that it's the medication side effects. I'm not tolerating it because I'm having a reaction to it. So I like to explain what it's doing and that the side effects are really from the lack of testosterone in your body, not necessarily that you're not reacting well to the medicine or something like that. So I think when a patient really understands the why, what we're trying to do with these medications, then they're a lot more likely to accept some of these side effects and figure out, what is something that I can tolerate and what is something maybe that's really affecting my quality of life. So I just think that little bit of a couple sentences of education, helping them understand why and what it's doing and why it can affect all these systems, and then shifting to let's be proactive. Let's see what we can do in terms of getting you on an exercise program. So I start talking about that primarily. So where are we? And the number one thing we can do is exercise. I wish we could bottle that up sometimes. And then at every single visit, I think it has to be revisited. I have so many times a patient will come who's already on ADT and they're like, oh, nobody ever told me that. I'm sure that they told them that, but you forget. It's a lot of information coming at you. So I think every visit when they come in, we sort of have to assess, okay, what are we doing? This is working, that's working. On my end, the medications, you're tolerating it well, you're not. And then what are you doing? Tell me what your diet is. Tell me what your exercise is. And really hold them accountable. Give them a distinct program. I don't think it's good enough to just say, here, take some vitamin D, stop smoking, and try to exercise 3 days a week. I really think laying out a plan with them, a program with them, and holding them accountable is really important.
I love that. I totally agree. And expectations are everything. So having that discussion about what to expect, whether it's hot flashes or fatigue or erectile dysfunction, and then what can they do, because they are very much a member of this team, and they're the ones who need to kind of be involved in helping to combat these. So having an exercise plan, like you're saying, thinking about what dietary modifications may be beneficial, and really encouraging them, I think is key. So I love all of that. Now, you mentioned
love to talk about the multidisciplinary team, and my another sentence I love is that they're the most important part of that team. So it all starts with them and like the things that they can do and be an advocate for themselves for the things that they can't control. So we can help work with them on that.
Right. They're going to have what I sometimes tell patients is that this will be a new baseline, but it will be one that is manageable. So you had mentioned vitamin D, and that makes me think about the bone side effects and how we can encourage bone health for patients who are on androgen deprivation therapy. What do you do in your practice for patients and their bone health?
So first, depending on if it's going to be a short term or a long term, we'll get a DEXA scan. We'll see where they're starting, see what other factors we can. If they're smoking, we're going to tell them, stop smoking, all those things. And then we're sort of reassessing if we need to start them on an anti-resorptive, then we'll do that. But we don't do that on everybody unless we feel there's a need. Sometimes we'll just try to balance it out with stop smoking, do that exercise routine with resistance training, weight training, certainly start there and go further if we need to.
Yeah, calcium and vitamin D is important. And walking, I tell all patients the importance of walking. Now you mentioned the anti-resorptives, and typically we think of skeletal related events for patients who have castration resistant disease. But there was a paper that was published recently in JAMA Open Network 2024 looking at the use of bisphosphonates and denosumab for patients who have metastatic hormone sensitive disease. We have to consider that those patients are getting steroids, and while we know that there are benefits associated with using abiraterone for patients who have metastatic hormone sensitive disease in terms of delaying disease progression, there can be some kind of weakening of the bones associated with steroids in these patients who have metastatic disease. And so in that paper that was discussed at the AUA as well, there was a potential suggestion that using these bone modifying agents may provide benefits to this population, although we don't see that recommendation yet in the guidelines.
Christian, can I make a comment on that?
Yes, please.
So one way to organize the thoughts, for someone who might be not as well versed, right, is to think of bone modifying agents, whether we're talking about zoledronic acid or denosumab, would be by setting. So hormone sensitive disease or metastatic hormone sensitive disease, we do it, but we do it with the intention of preventing osteoporosis related to complications. So that's the DEXA scan. We got the FRAX score, if you will, and when we do that, we do it with the drugs, same drug, different brand names for osteoporosis, right? So Prolia, Clusta, so same different doses, same drugs, and we do that once a year or twice a year, respectively, zoledronic acid and denosumab, with that intention. We don't do it with the goal of preventing skeletal-related events related to bone metastasis. So this is different dosing, but also scheduling to what we are used to mention bone modifying agents, which has to do with metastatic castration-resistant disease, where we'll do it to prevent skeletal-related events. Many of them end up being SSEs, symptomatic skeletal events, and we do those. We historically used to do them once a month, right? And the reality is, we have more recent data suggesting every 3 months seems to be non-inferior to the monthly treatment with denosumab or zoledronic acid, but it appears to minimize or is less frequent complications of interest, including osteonecrosis of the jaw or hypocalcemia, excuse me. Therefore, when we talk about the same therapies, important to recognize the setting, because what we do and when and how often we do it can be different. And we do see a lot, right? Patients getting zoledronic acid monthly or denosumab monthly in a metastatic hormone sensitive disease, and we really don't have the data to support that. And so important to understand where we're using it and the intention why we're doing it.
Thank you. Very important clarification there. So just one more comment about the cardiovascular risk. We know from the HERO trial that potentially there's some decrease in major adverse cardiac events with using the oral relugolix over using leuprolide. Do you, in your clinic, counsel patients in a certain way about that, Rachel, or how often are you getting cardio-oncology involved in the care of these patients?
Yeah, I think as we're taking our initial intake and risk factors, I will sort of consider some of it's patient driven. They prefer an injectable and oral. Some of it's insurance driven, unfortunately. But we do counsel, and I will, especially if I'm worried that a patient won't tolerate for side effect or for cardiac, we will do the oral medication instead. They like the idea that, like you said earlier, it's quick on, it's quick off if we need to, as opposed to a long acting. And I'm pretty quick to get cardio oncology involved for these patients up front, because obviously we can't predict what's going to happen down the road. So if I think they're a high risk factor, then we'll get them involved pretty quick.
Great. And that's a good segue into some of our final topics. In many of the AUA 2025 prostate cancer sessions, we learned about embracing multidisciplinary care. Dr. Morris was faculty for one of those, and certainly in Dr. Cookson's advanced prostate cancer courses, we talked about the importance of multidisciplinary care. Dr. Cookson, what does multidisciplinary care look like at your institution, and who are your go-to consultants when managing some of these really complex patients?
Thank you for that question. It's an evolving team, and a team that keeps getting bigger. I used to think, man, we're really doing a good job. We've got an oncologist, a radiation and medical oncology. We're there. But you've already explained. I would say, while the patient is the center and the whole goal is to provide them with the most efficient and best outcomes and offer them enrollment in clinical trials and standard of care, evidence-based, research-based treatment options, I think the nurse practitioner and the PAs are really at almost the top of the provider list for the reasons that you just heard. But it includes others. So we're talking about building in things like tumor boards, where you bring in the nuclear medicine team and you bring in the PET scans, you bring in pathology, you bring in, we make the genetic testing, which takes a separate conversation. Often genetic counselors, if they're available to you, that's part of the team. Some people need nutrition. Some people, so there's a lot of things in there. The cardio oncology, I will say one thing, that it's important to look at their health. And in studies that have been done with agonists and antagonists, where there was a good look at their cardiovascular health, they were placed on statins if they needed it, they're under monitoring. I think the differences there blur, not as profound. I think if you're just talking about manage patients, then maybe there's a slight advantage. So there is some controversy in that space, but I think that if you give patients the option, see their primary care or their oncology or their cardiologist they need to, and they get the proper attention to their heart, then I think you're going to see that potential side effect mitigated. But it's a whole team. It's a team approach. It doesn't have to be one stop, one day, everybody all in one bucket, because sometimes that's not very efficient in modern healthcare. But it is trying to set it up where they can get to as many places. At a cancer center, we often have the ability to see med-onc, urology, radiation all in the same day, but usually not in the same clinic, because not everybody needs everybody at the same time. But it is a team approach, and the team adds as the needs increase around the particular patient. But clinical trials is an important component of it. They have their own nursing that come in, and it's very time consuming. It's truly an investment. So we have to be committed to it, because it is, from a provider standpoint, not always a model of efficiency, but it's patient centric and it's about the patient. And so I think that's how it works in our shop.
Great. Well, that's I think a really important part of care for these patients. And part of that too involves bringing in folks who can help with managing some of the financial stress associated with some of these really exciting and promising medications, but they also are quite costly. And so I'd love to hear from Dr. Morris about financial toxicity. What does that mean for our patients? And how do you at your institution help patients navigate the cost of some of these really expensive drugs?
Thank you. I think it's really the rubber meets the road sort of question. Is the clinical data is great, but if you can't get the drug to the patient, it really doesn't matter. Thankfully, some changes recently with the IRA Act for Medicare beneficiaries. So thinking about commercial pay, there's a lot of copay assistance programs from manufacturers for patients with no drug coverage, prescription benefit plans. There's often manufacturer free drug access. And then from the Medicare, now out-of-pocket cap of $2,000 in a year, which even allows smoothing and spacing out the payments over months instead of one lump sum payment that would cover their out-of-pocket. All those things have made it much more accessible for patients, and the grant foundations that help support patients being able to make those out-of-pocket payments have been able to spread their money out to more patients. So it's actually worked as designed, which is, I hate to say that surprises some of us, but anytime a program like this launches and works as it's supposed to, we're very excited for it. But it does take some counseling, whether it's from your office or in a large academic institution. There's pharmacy people that have to basically walk the patient through that process. It's not usually the physician, but usually it's us turning them over to someone who's going to get you through the grant applications and things like that. But with the hit rate now is much higher than it was a few years ago for being able to get patients on products.
Yeah, a lot of exciting work happening there, and we need to definitely make sure that we have an understanding of what these medications cost and how we can help our patients get the medications they need. A lot of work by one of my colleagues, Dan Joyce, in this space, so stay tuned. All right, so along with these patients that have advanced prostate cancer and they're navigating the stress associated with a diagnosis like this, and then the side effects of medications and the cost, having advocacy groups and places where patients can turn outside of their maybe friends and family for support. There's a lot in prostate cancer. Rachel, what support groups do you recommend for your patients? What resources do you provide for them?
Yeah, I think it's really important. Resources are important for everybody, but especially in this space, I think, letting patients just go to Dr. Google benefits nobody other than my in-basket. So I try to set up, every patient has unique and individual needs. So I utilize a website where I can kind of put a lot of different resources up there for them, try to steer them towards more reputable places. The AUA Urology Care Foundation, they have some really good information out there for patients. Prostate Cancer Foundation has really good information actually on AUA, on ADT, and preventing these side effects or helping to work around them. And then some support groups. I tend to encourage patients a little bit to stay away from general support groups or like Facebook forums, because I think that just leads you down a rabbit hole of a couple of patients' bad experiences. So I think it's important to have those kind of laid out and direct patients to good places to get good information. So the AUA's resources there and Prostate Cancer Foundation, I think, are really great.
Agreed. Yep. Zero Prostate and Movember are a couple that I also direct patients to. Dr. Barada. So still a lot happening in this space. We've seen so much development and so much more. It's kind of rapid fire how quickly things are being developed. What do you think are some important future directions? What are you excited about in this ADT space, or kind of navigating side effects or de-escalation? What do you think? Where?
Right. Yeah, great question, right? Where are we going? I guess the first thing that's going to happen, if without being, is actually the use of treatment combination strategies are going to continue to increase. It's never going to be 100% because of all men we see metastatic disease. We have a fraction of them that unfortunately are not facing mortality because of prostate cancer. They have significant comorbidities, might be at the hospital. And so the ceiling might be somewhere around the 80% or so, but we'll continue to see that increase. So one thing is, what can we do? On one end is giving more therapies. The other one is to give less therapies. And what I'm trying to describe is how can we personalize what we're going to do? And I think that's really the future. So the way I have it organized in my head is the following. Number one, we will start incorporating molecular makeup of the tumors in addition to the clinical characteristics of the tumor and the patient, right? Whether it's DNA alterations, whether it's RNA seq data, also known as genomic signatures or gene expression signatures, right? Or maybe a combination of it. I think we will find a way, maybe AI can help us with that. We'll find a way to understand how do patients going to do from the prognostic portion of things, so we can start categorizing patients in a much fancier way, based on that. And based on that, and whether or not we have that, we all understand in clinic that some people need more, some people need less. So talking on more, things that are very likely going to come up within the next year to 5 years are things like biomarker-based approaches. We will know in a few months that treatment directed to P10 for patients with P10 loss will benefit from the addition of a target therapy called capivasertib. We will also know, likely, that an addition of a PARP inhibitor in this particular setting, in addition to the RPI ADT backbone, will probably improve outcomes, at least controlling the disease from progressing, right? So those are just two examples. We also likely going to see whether or not radioligand therapy, things like lutetium, PSMA, and others, will play a role in controlling the disease for a longer period of time. And then we'll see if that translates into survival advantage, but also in this setting. So this is all under the category of doing more. On the other side, we'll probably also understand that some of the patients do well, so well for so long, that actually doing what we're doing today might be harming them because we're over-treating them and we expose them to unnecessary side effects. So things like de-intensify or de-escalation of therapy are important to continue to be explored. We have some efforts in that direction. I'm thinking of the trial called Libertas, kind of doing that with the RPI. We probably going to be more cavaliers in just stopping actually all systemic therapy, including castration, right? We're trying to do that already, or those patients with oligometastatic disease, which is a niche within low volume disease. So I think that treatment de-intensification and then treatment intensification, whether it's upfront or at some point, like adaptive designs, I think they're going to be more relevant as we are looking ahead within the next, year 2 to 5 years. So, it's going to be a little bit more complicated. We're going to keep learning a lot more. And our guess is we're no longer going to have this conversation about, let's do an ADT RPI and that's it. Maybe triplet for a very few. I think the algorithm of our approach is going to be more complex.
More complex? How can that possibly be? So as we wrap up today, I just want to acknowledge all the important work that's been done to advance care and improve outcomes for our patients and express my sincere optimism about the promising future in prostate cancer. So Drs. Barada, Cookson, Morris, and Ms. Hastings, thank you so much for your time today to discuss this very timely topic from AUA 2025. Thanks all.
Thank you.
Thank you.